So shock is essentially a condition where the tissues and particularly cells don't receive enough oxygen. It may be because of a problem with the oxygen delivery, or because the tissues are in an increased demand of oxygen and it's not met. It could be a demand versus supply situation, or inadequate oxygen utilization, or it could be a mix of all these things. So with this basic premise, we will move on to the different types of shock. The commonest shock we encounter is probably hypovolemic shock. Hypovolemic is when we lose the circulating volume and the intravascular volume is lost, either due to, say, profound GI loss from diarrhea, vomiting, or extreme blood loss, say from a pelvic fracture or a crush injury of some sort. And those would be examples of, or a massive hematemesis. All of these would be hypovolemic shock. Hemorrhagic shock is a subset of this. Distributive shock is when there is extreme vasodilatation and the blood either pools in the peripheries or gets redistributed into the third space. So in dengue, it's a classic case of fluid redistribution in the third space, and you don't have enough circulating volume. Whatever you pour in also leaks out. So that's with dengue. So, or it can be in a situation where in sepsis, where the capillaries become very leaky and the intravascular volume is lost. So that is a distributive shock. Obstructive shock is when you would have there is either, say, imagine a pulmonary embolism. So as the blood gets out of the right ventricle, in the main pulmonary artery or in the pulmonary trunk, there is a huge clot sitting there, and it doesn't allow the blood to circulate. So that thereby causing obstructive shock. So in a tension pneumothorax, the similar thing happens where, because of the increased intrathoracic pressure from the pleural air, that doesn't allow venous return to happen. So that causes obstructive shock too. So when the preload is reduced because of the intrathoracic pressure, there isn't much circulating volume. So that is obstructive shock in a tension pneumothorax. It's a similar situation in cardiac tamponade too. So these are different types of shock. Yeah. So we're just going to look at case by case with these basic understanding of shock. So we're going to talk through different types of shock. So let's look at this case situation. There's a 54-year-old woman who's had a previous PTCA, and she's got a poor LV function. She's got an EF of only 40%. She was in a back seat, and she sustained a flexion hyperextension injury. She was a backseat traveler, unrestrained, so she was thrown in, and she came in with severe neck pain and bilateral upper limb pain, and she also had weakness of all her four limbs. So we suspected a C-spine injury, and you can see that I would like to highlight the third box, the one about circulation, where it says blood pressure is 70/40 and heart rate of 65. And she is quadriplegic. So anybody wants to venture a guess? So it's very clear. This lady has got what we call a neurogenic shock. It is not a spinal shock. Spinal shock is a misnomer. It's not really a true form of shock. It's a term that we use when there is a flaccid paralysis. Neurogenic shock, on the other hand, is something that we use to describe when there is a sympathetic paralysis and the blood pools in the peripheries, and that causes a shock. The preload is affected. So it is a kind of a distributive shock. Neurogenic shock is a kind of distributive shock. So this lady, we are not making up these numbers. This is an actual story, actual cases. You can see that there is a huge metabolic acidosis, base deficit of minus 14.7, which is minus 15, and a lactate of 7.68. So this woman had quadriplegia and she's got all these metabolic derangements. The chest X-ray did not show anything to suggest in trauma. Until proven otherwise, we need to believe it is hypovolemic or hemorrhagic shock. We need to search for blood loss, which is why this woman had a chest X-ray and a pelvis X-ray, and all of which was negative. And she had a EFAS as well. We couldn't see if there's any blood loss elsewhere. So with all this, she was identified as having neurogenic shock. She was given fluids. Okay, so one of the key reasons I put up this lecture was generally people equate hypotension to hypovolemia, and they invariably start off throwing in fluids, IV fluids. So that shouldn't be the case. You need to try and figure out why is she in shock. Yeah. So this lady, even though she had fluids, and not all shocks will need fluids. So, but this lady was optimized. Her intravascular volume was optimized with, say, 750 ml of fluids. She was carefully given fluids because she had a history of coronary artery disease and a poor LV. So, despite which a BP only came up to 90 or 50. And then she was started on noradrenaline. Remember, I did tell you that she had neurogenic shock, sympathetic paralysis, and she was started on NORAD to bring a map to above 70. And we had to monitor. Whenever you are using a vasoactive agent like NORAD, you need to place an arterial line to monitor the blood pressure. And before you start somebody on NORAD, you need to be certain that their intravascular volume is optimized. So you basically have to give them some fluids and then start them on NORAD. Yeah. So this lady, in fact, needed subsequent adrenaline too, after which she ended up having an evaluation of her spines. We do know that she is quadriparetic, and we couldn't see, as you can see, there is no gross subluxation or gross bony injuries in the C-spines. However, the MRI revealed a cord injury. You can see that there is a cord injury with cord edema. So at the level of C6. This is much more common in children, where we call spinal cord injury without radiological abnormality, or at least bony fractures. So this woman did not have much that could be picked out with a CT. So she only had injuries which were picked out with an MRI. The general rule is, how do you pick out which investigation, which imaging modality, CT or MR, depends on their neurodeficit. If they have neurological injury, which is with demonstrable weakness, etc., an MRI will be better. If you want to delineate the spinal cord and its structures, MRI is better. If you want to look at the bones, specifically the vertebrae, etc., so a CT is better. So this lady, we thought she will have a certain fracture, and we did a CT, but unfortunately, or to our surprise, it was negative, and the MRI picked out a cord injury. Yeah, so this woman had significant narrowing. Okay, the neurogenic shock happens only with a high cord injury, cervical and upper thoracic. They usually say T6 and above, but even with T6, it's not all that pronounced for you to have a neurogenic shock, which is characterized by the classic finding here is that she's not tachycardic. Yeah, so they have relative brady and hypotension. Yeah, so like I said, it's sympathetic paralysis, so they wouldn't mount a tachy. Yeah, so this woman had a high cord injury with a neurogenic shock. And again, the highlight of how you would manage this is optimize intravascular volume. And in any shock, the first thing to do would be check the ABCs, give them adequate oxygen, and then optimize fluids and start them on vasopressors. So this woman, despite needing NORAD, also needed a touch of adrenaline too. That may be because of a cardiac status. Okay, so we've already talked enough about neurogenic shock, sympathetic cutoff leading to vasodilatation. NORAD is the first choice vasopressor. So Second line vasopressin maybe, but adrenaline was chosen in her case. Yes, you need to optimize intravascular volume. Yeah. So phenylephrine is another choice, and it's an alpha agonist that can be used because of its peripheral vasoconstrictive properties. But this needs to be properly diluted, or else it will be a disaster. Yeah. So phenylephrine, the other problem is it can cause a bit of brady. So you don't want that in a patient who's already bradycardic.